criteria, our programming, and maybe talk about our admission process, and might help you guys better understand how to, I guess, learn all you can while you're finishing your rotation on the side. So on 8A, how many of you have been on our unit already? Everybody? No? Okay. All right. So our unit on the 8th floor is divided into 3 parts. We have our back unit, which is our locked unit. That's PICU, or our psychiatric intensive care unit. We also call it 8C. So most of our patients who are admitted to behavioral services, they usually, not always, but usually start on 8C. And they start there because on that unit we're able to control the environment. We have rooms that are line of sight. We're able to safely keep an eye on them, monitor them closely, make sure that they're in a safe environment. People who are often admitted to PICU are a danger to themselves or others, or gravely disabled, and are often in crisis. So we want to make sure that they're safe and can be watched at all times. On 8A, we have 23 beds. That is our least restricted area. So when patients start to progress, when they start to do better, they're able to move out onto 8A from PICU. Oh, and there's 17 beds on PICU. 8A, there's 23 beds. 8A, patients can be admitted directly to 8A, but they need to be a little bit more stable. Those rooms are not line of sight. They're actually down a long hallway, and the nurse's station is towards the end of that hallway. And so we need to make sure that they are not actively suicidal, that they're not actively homicidal. We want to make sure that they're going to be safe on that unit. Some patients on that unit are maybe still having some psychotic symptoms, but they're managed. So they're able to participate in the milieu and interact appropriately with other patients and staff. 8R, that's our recovery unit. It is located on 8A, and there's 8 beds up there. And that's where we detox. We detox off of alcohol, benzos, opiates, although there have been a lot of changes with the opiate epidemic. Unfortunately, insurance companies are no longer covering straight opiate detox, and so we have to be careful to recognize any comorbidities that may be going along with the opiate detox, which there almost always are comorbidities, depression, anxiety, or something else. At Jerry's Psych, we have, did you want me to talk about Jerry's Psych too? Is it in the rotation?
They're not in this rotation, but you can talk about it.
Okay, all right. So Jerry's Psych unit has 16 beds, and it's located here off the Otter Creek exit at the Southwest campus. And we are actually in the process of expanding it by 8 beds. So we're almost always full load there. With the baby boomers aging, there's a great need for Jerry Psych services. So we're expanding services there currently. There we have nursing staff, we have an activities person, we have a therapist, a discharge planner, pharmacy's usually out there, so it's its own little unit out there at Southwest. So I'll talk to you a little bit about the programming, what we're able to provide. So on the 8th floor, our length of stay is pretty short, typically 3 to 5 days. So our unit is very busy, it's very fast paced. So do you guys have any questions so far? I'm kind of going through this kind of quickly. No. So during those 3 to 5 days, we offer group therapy, individual therapy, occupational therapy. So the way our day looks is in the mornings are psychiatrist rounds. They see the patients. We have usually 3 to 4 different psychiatrists there on the unit that see our patients, and 1 APN. And so our psychiatrist round, and then at 9:30 our recovery group starts. And so that's where we treat addiction. We have a therapist who specializes in addiction. He has a lot of experience in leading group therapy for addiction. And so he does groups, and he works specifically with those 8 patients that are in the detox beds. He does all of their discharge planning. He helps them get into rehabs after they leave the hospital, if they choose to do so. You know, we have to kind of gauge their motivation and see what they're willing to do or what they want to do. And then, and he works with them during their 3 to 5 day stay and through their detox. We will medicate any sort of symptoms that they may be having, but we don't typically prescribe anything that's habit forming. We don't do any sort of medication assisted, like Suboxone, Methadone, Subutex. We don't do anything like that. So we will just strictly medicate the detox symptoms, the withdrawal symptoms. So nausea, vomiting, sweats, we'll treat all of that. So, and the patient, even though the patient will probably feel bad, we do encourage them to attend group and meet with your therapist, because we want them to get all they can out of treatment during those 3 to 5 days. And then for the psychiatric patients, at around 10:30 after our recover group, we offer a didactic education group. And that's where we provide like some psycho education. It's amazing to me how many patients don't fully understand their diagnosis. So they really need education on what they've been diagnosed with, the evidence-based treatment for that, different coping skills that they can use to deal with this illness, and maybe even some local resources to help them. And then after that, they have visitation, and in that afternoon, they have occupational therapy with our occupational therapist, and then after that, we have another psychotherapy group. And that group is where the therapist leads, and they are able to process more with the patients, really get in there and talk about some of their issues and have the patients relate to each other and build more of a support system there on the unit, because many of the patients still have support outside of the hospital. So, do you guys have any questions about group therapy? What do you see as your role in group therapy?
Encouraging them to go.
Okay, encourage them to go. Okay. Anything else? What is it? Safety? Okay. I would encourage you to sit in and take part. Sit in that circle and say your name, take part in the group, learn what it's like to sit in that chair. And because I'll tell you, it's not easy to sit on that couch and talk about problems, you know, and so putting yourself in that situation will help you gain empathy. It will help you learn what the patient may be really struggling with. You know, you'll learn some sitting outside, but you'll learn so much more by participating in the group. So I know the therapy staff, they've been instructed by me to encourage you guys to sit in the circle and participate. And so if you're on the unit, I would encourage you just to take part and sit in that circle and be right there next to the patients, you know. And just to give you another perspective, when there's a small group of patients and then there's a large group of nursing students, it can be very intimidating to them, and they don't open up as much. And so if you're sitting with them rather than outside, it creates a whole new dynamic. And so it's really beneficial to them for you guys to be in there taking part. So, do you have any questions or comments about that? Yeah.
The group therapy, do y'all like group them by like what they're detoxing off of, or just everybody all goes to the same group?
In the mornings, all the detox patients, they all go to the recover group. In the afternoons, they're all required or encouraged to attend psychotherapy. All the groups are encouraged. The only time that group is not encouraged is if a patient is psychotic and would not benefit from group. If a patient is agitated, if they would not contribute, because you have to think of, the therapist has to think about the group as a whole. And so if the patient can contribute and benefit the group as a whole, then yes, they should attend. But if they don't have the ability to benefit from the group and they won't benefit the group, then they're not appropriate to attend group. So we want them to be somewhat stable and at least able to process the information to attend. They may not be up to sharing, that's okay, but they at least need to be able to sit and listen and maybe process. So with that being said, even some detox patients who may not be feeling well, if they can process, they should go to any of the groups, all the groups, just get as much as they can. Because usually, you know, in groups, we have so many different people, so many different topics come up, and our therapists do a really good job of recognizing the variety that's attending our group, and so they're able to manage that so that each person should be able to get something out of it. And we have different days we do different topics. So there might be one day we talk about coping skills. The next day we might talk about conflict resolution. The next day we might talk about stress management. You know, and so we have different topics that we do. So something else we do, sometimes the doctors will order family sessions, so we'll meet with the family. It's always amazing to me how, once again, little the community or families may know about mental illness, and so it's a real opportunity for us to educate, for social work staff or nursing staff to sit with the family and the doctor and be able to talk about diagnosis and medication and follow-up plans, and really help the family understand what they're looking at, because there's many times they just don't know. You know, and it's really hard to take care of somebody with a mental illness when you don't know. And then the discharge planning piece is something else we offer. We want to know about the person's environment. Where are they coming from? What are they dealing with outside of the hospital? A lot of times that's a precipitating factor that causes them to come into the hospital. You know, it's really hard to combat depression whenever you don't have, you know, a place to sleep or food to eat. And so we try to help them with those resources, try to help them get outpatient providers so that they can get their medicines filled. Sometimes we fill their medicine before they leave the hospital just to make sure they have it and they don't have to, you know, go find another bus token just so they can make it to Walgreens and then try to get to the shelter by 3 o'clock before all the beds are full. You know, and so we try to be mindful of all of that.
Is that difficult when they don't have a place to eat or a place to sleep or anything like that, to get them placed in places where they're going and being discharged to?
It can be, especially if they have a criminal record or if they're a sex offender. That can be very difficult, because a lot of the shelters also have programs for women and children. And so if it's a male sex offender, they're not allowed on that premises or anywhere close to it. And so sometimes there's not a good place. And those discharges do not feel good to us. We don't like them, you know. But sometimes, you know, patients just have to go back to where they were before they came into the hospital.
So, in that 3 to 5 day period, if they haven't got any better, what do you guys think?
keep them longer. We keep them longer. The 3 to 5 days, that's our average. So there are outliers. There's many patients, especially from my experience, I've seen a lot of the older patients who have been dealing with chronic mental illness most of their lives. It seems like it takes them longer to metabolize the medicine, and so they don't bounce back as quick as some of the younger mental health patients. And so, and there are some, it just takes a while. They're that sick, their prognosis is poor, and so they end up staying. We have one lady, and this is probably the longest stay I've ever seen. She's been there about 50 days. And we have her on Clozaril, which is a very strong antipsychotic, one of the kind of last resort antipsychotics that requires lab draws. But we waited to start the Clozaril because she doesn't have family support to make sure she gets the lab draws. And so, we're going to make a report to Adult Protective Services before discharge and hope that they will help, and maybe we can get her into a group home, we're hoping, but she doesn't, it's a difficult population to work with because there's so many factors. Yeah. But, they need our help.
Did you see a lot of repeat people come back?
Mm-hmm. Yeah, there's a lot of people that you really get to know because they are repeat, mental health. There is an issue with compliance. They get sick, they won't go to appointments, or they won't, they miss their medicine, or they become paranoid, won't take their medicine, or, a lot of times families, sometimes family members are just as sick as the patient, and so they may not be the most supportive. And unfortunately, Medicaid just passed some changes that they're now taking away case management. And so now I'm afraid of what's going to happen, now that Medicaid's no longer going to cover case management. So, yes.
Could you explain the mental state between voluntary and involuntary commitment?
Sure. So voluntary patients, they come in, they sign in for treatment. That means that they agree that they need some help. They agree to treatment. Involuntary patients are, they feel that they don't need help, they don't need treatment, they don't need to be in the hospital. And so at that point, the doctor places them on a 72-hour hold. So that means that they are a danger to themselves, danger to others, or gravely disabled. They have to meet that criteria to qualify for a 72-hour hold. So, at that point, the court is faxed paperwork stating that they're on a hold, and the social work staff notifies either the family or someone who has firsthand knowledge of the patient to give them the option to file a petition, which means they contact the mental health court, the probate court, and they can meet with the attorney there, file a petition, and the patient will go to court, go in front of the judge, go in front of the attorneys, and they will decide whether or not the patient needs to be there involuntarily, and they can either grant or not grant what they call a Section 5, which is a 7-day eval. So that means we get to keep them for an additional 7 days to further evaluate and treat them. Now, during that 7-day period, we are not allowed to give long-lasting injections. We're not allowed to force treatment. It's evaluation. We can give PRNs as needed, but we cannot give like an in-vagus systemic injection. That would be long-lasting.
But how long be a long-lasting injection?
Well, they would have to, in order to get a long-lasting injection, which they typically last about 30 days, they would have to be on the next level of court order treatment, which is a 45-day court order, and that's in section 9. And at that point, the doctor has to go to court and testify. And we get a lot of patients that are on 45 days. And what we do is we ask for outpatient treatment or group home placement to be included in that court order. And so that, we don't have to necessarily keep them for that 45 days, but we're able to get them on the medicine that they need to be safe, and we're able to get them to the next level of care, and they be court ordered to that placement. So they have to go, and if they don't go, they'll be picked up by the police.
So with a voluntary commit, how long does an individual usually submit to stay?
Voluntary,
Yes, ma'am.
typically, the average length of stay is the 3 to 5 days, unless they're just really sick and need some extra time.
Okay.
Yeah, and of course, we coordinate with the doctors, the insurance company, we all work together to see, how that works.
But if they're voluntary, they can leave at will. Do they have to say?
Sometimes the doctor will let them go. We notify the doctor when they start asking to leave. The doctor decides whether or not they need to stay. If the doctor feels that they're still a danger to themselves, then he can place them on a hold at that time. Or he may decide, okay, yeah, they can go ahead and discharge. Or it may be against medical advice, an AMA. So it can happen in other places.
So the patients like on Medicaid and they're getting rid of like social work for that. So like, would it have you be like fall under like the nursing being advocate of where to find them to go, or like, or is it kind of just like, okay, well, we can't do anything, so.
No, case managers, that's being cut at a community level.
Okay.
Not in the hospitals.
Okay.
It's like Little Rock Community Mental Health, Professional Counseling
Okay.
Associates. Some of the community mental health centers that receive state funds that are, because case management only bills Medicaid.
Right, okay.
Yeah, and so, and they are, sometimes they're not social workers or mental health professionals, paraprofessionals, different levels of training. But yeah, Medicaid's cutting that, which is still unfortunate because they're often the ones that help patients manage their funds, fill out housing applications. Yeah, learn how to function in the community. I mean, they're a big part of patients being successful outside of the hospital.
I have one more question.
Yes, ma'am.
What is the rationale behind a nurse using the most restricted, chemical restraint as the first choice of restraint or intervention?
We try not to use restraints. First, we use verbal de-escalation. We want to try to talk them down before we do anything. And of course, if they're psychotic, then we'll use PRNs and try to hold on at a band, if the doctor orders that. But it's hard for me to speak to chemical restraints and all that since I'm not a nurse, I'm a therapist. So I don't want to give you the wrong information. But typically, what we do is verbal de-escalation. We try to talk them down. And of course, if that doesn't work, sometimes we can offer them time in our quiet room or seclusion room, but we'll just leave the door open, but just give them a little bit of time to themselves, time to pace, time to, be upset, be angry, whatever they need to do to get that energy out. And if that doesn't work and they're acting out, even, when we give them some time to breathe, then sometimes we'll get the PRNs. But we try not to. We don't want to have to give people shots. Yes, ma'am.
What's like the most common, mental illness that's seen?
Oh gosh, we see so much up there. That's really a hard question to answer. We see a lot of depression. We see a lot of suicidal ideation. A lot of anxiety. We see a lot of schizophrenia. A lot of borderline personality disorder. I got a reaction out of that one. What's that reaction about?
I'll watch by the time we need
The three factors,
Homicidal, suicidal, gravely disabled.
so do they have to have all three to be
No.
criminal, or just one?
Just one. Yeah, if they're suicidal, if they're a danger to themselves, that meets criteria. Or if they're saying, if I get out of this hospital, I'm gonna go kill so-and-so, then that's homicidal, they can be placed on a hold because that other person is in danger. And then a person gravely disabled, if they're so psychotic that they can't function, then they need some help.
Okay, this is just one topic. But we had a lady in the bill that said she was going to push us to probably that. She told us that she wasn't really going to trying to get her out of that recovery. So they told her that they were going to take her to the ER where it would be decided if she would be put on a $72 hold or not. Is that accurate, or does she automatically go on that hold because she attempted suicide?
She attempted,
She did not remotely successfully attempt it.
what was her attempt?
She said to her husband that she was going to give up pills, and she never did. And he has
So she threatened and didn't attempt, but she threatened. You know, I do a lot of those assessments in the ER, and I would really have to consider all the risk factors that goes along with a person like that. Does she have a mental health history? What's her living situation? What kind of support does she have? Does she have a parent that's committed suicide? Has anyone else in her family committed suicide? Does she have a history of trauma? Is there a history of abuse? Is there, you know, there's so many factors to think about, you know, and, you know, with a personality disorder, there are many times where they may make a threat, they may make an attempt, and sometimes they up the ante, you know, and that can be really scary, you know, and so we have to be very careful in our assessments and consider the whole picture, the whole environment, you know, what kind of support do they have? Have they ever been to a therapist? Have they ever, you know, received treatment? Are they on psychotropics now? And really look at the whole person. That's a hard one to answer. I would probably, if she was contracting for safety at that point and was saying, no, I'm not going to do anything, I was just saying that, then I would probably just document that very carefully, and I would probably have the husband in on some of that conversation so I can have collateral and put every bit of it in the chart, and I don't think at that point it would warrant a 72-hour hold. Were you gonna ask? Okay, so I guess I'll move forward with maybe talking to you guys about what your role can be while you're rotating through the unit. So we have occupational therapy, we have therapists, social workers or therapists, same thing, and then nursing. And so you are welcome to follow any of those disciplines around. You know, if you want to see a therapy session, just talk to the therapist about it, see if it would be okay for you to sit in. Now, that being said, you guys rotate in such large groups, we wouldn't want 5 students to 1 therapist and 1, but if it's 1 nursing student, 1 therapist, 1 patient, then I would think that that would be okay. So if there's a case that you're interested in and a therapist that you're interested in working with, just talk to them about it. Same thing with our occupational therapist, Beth. She has been there forever and she's a wealth of knowledge. So if you ever want to shadow her or pick her brain, she'll gladly talk to you. Same with our nurses. So you're welcome to talk to them. I will say that with group therapy, if our census is low and there's not a lot of patients in group, that may be a good time to maybe divide up, because we don't want to have 5 patients in group and, once again, 10 nursing students. So I always think it's a good rule of thumb that if there's 5 patients in group, let there be 5 nursing students in group. That way, once again, they're not intimidated or overwhelmed, and they'll be willing to share and get all the benefits of therapy. So are there any questions about that?
I have one.
Yeah.
Is group therapy mandatory for the patient?
It's not mandatory, but it's strongly encouraged. We want the patients to get all they can out of treatment while they're there. So we strongly encourage it. If a patient's been isolated, we may really push them to go to group, because we don't want them isolating and staying in their bed all day. So we'll really try to pull them out of their room and encourage them to take part in that venue. In the mornings, our nursing staff, they do a community group, and that kind of sets the pace for the day, lets the patients know what the day's going to look like, lets them know the schedule, what all groups are going to be done that day, when visitation is, when lunch is, that sort of thing. And then at night, the night shift does a medication group. And so we work closely with nursing staff to provide some activities and things for them to do in regards to medication groups. So, so our patients are busy pretty much all day until bedtime, which is good. We want them to get all they can out of it. So I've talked a little bit about admission criteria. So admission criteria to 8C, and this is so, and I guess kind of reviewing this briefly so that you guys know that if you see a patient, maybe on the medical floor, another part of the hospital, that you're like, oh, there's something going on there. It might help you decide, okay, well, they may need some help in PICU, or maybe we need to call and get a referral to 8A, or maybe they need detox. So I'll briefly go through the different admission criteria for the different units. So 8A, if a person is maybe depressed with maybe some passive suicidal thoughts, they've had some thoughts, they don't intend on acting on them, they're just kind of fleeting, they want to live, they have a family, they have no intention of harming themselves or anybody else. They're just really depressed and having some intrusive thoughts. Then they may be a candidate for 8A, and it may not be necessary for them to go to the ICU. So we could look at maybe screening them for 8A. If someone is maybe has schizophrenia, maybe having some hallucinations, but they have some insight into their illness, they're not agitated, they just maybe need some med adjustments. We could even look at 8A for them too. It just depends on their level of functioning and the severity of their illness. 8R, of course, is our recovery unit. So if a person is using drugs, alcohol, let me rephrase it. If a person is using benzos, opiates, alcohol, and with the opiates has comorbidities, then they will likely meet criteria if they've not already detoxed in a medical bed. Because a lot of times if a person, say they overdose, they take too much heroin, they go into SICU, they're there comatose for a week, and then we get a call, they need to come detox. Well, actually they don't, because they've already been down there a week and it's already out of their system. But, if you want to give them resources, then we can do that. So, we do get a lot of calls like that, patients wanting detox, but they've already been in the hospital, so they really don't meet criteria. It's time for them to move on to maybe residential or like an intensive outpatient or another level of care. But if they've only been here for maybe a day, they're starting to talk about wanting detox, then they may very well meet criteria, and they're welcome to do a phone interview with our detox nurse. 8C, or PICU, that's our psychiatric intensive care unit. And that's when patients are acutely psychotic, homicidal, or suicidal. So if there's someone that's psychotic, agitated, irrational, you can't talk them down, they're not following any sort of direction, wandering in and out of rooms, they need to come up to AC. We need to make sure that they're in a safe place. We want to make sure everybody else around them is also safe. We don't want them wandering around, potentially harming anybody. And then Jerry Psych, we see a lot of dementia there. We see a lot of patients who are depressed, maybe going through some difficult life changes, and have to come in to see our Jerry Psych psychiatrist, and sometimes get testing to see if they have dementia. We do a lot of nursing home placements from there. It can be a really tough transition for elderly people, having to move out of their homes, or maybe they just lost a loved one. So we do a lot of family work there, a lot of placements. So if you have anybody who needs psychiatric help, anyone who needs detox, Jerry Psych, our call center takes all the referrals. They look at all the, we get referrals from all over the state, from our own hospital, from the whole system. So they stay pretty busy over there. But that number is 202-7501. Or I'm sorry, 7006 is that number. 202-7006. That's the number if they need to be admitted to behavioral services, or if you want a patient considered for behavioral services. So, you guys have any other questions?
I've had a lot of patients go to Jerry Psych at my assisted living, but where do they go after? Because they don't come back. So do they just stay? Can they stay there for an extended time or
Typically, that length of stay is longer. It's usually about 2 weeks.
Oh.
And sometimes they require a higher level of care. As you said, you're at assisted living, so they may need to go to a full nursing home from our facility, because usually if there's mental status changes, they need some medication, and maybe they've decompensated some, and they just may need a higher level of care at that point.
Do a lot of y'all, patients, do they go to a unit to where it's locked down, or maybe, in terms of psych unit in a nursing home. So ours is called observation. We have a lot of you know what I'm saying, that.
Yeah, like memory centers.
Yeah.
Mm-hmm. Yeah, our Jerry Psych discharge planner is very up on all of the discharge resources, and so she places, some patients they tend to wander, and so they'll need to go to locked units.
What's the most memorable case you worked on?
Oh, most memorable? Oh gosh, there's been a lot. I tend to remember for some of the scarier patients, you know. There's a couple antisocial personalities that come in that, you know, there's no benefit, and this is evidence-based, there's no benefit to acute hospitalization for an antisocial personality. They don't benefit from it. If anything, they have a secondary gain from it, you know. So there is a guy who has been in multiple facilities who is just really scary, you know, mutilated animals and does a lot of self-harm to himself. Like he's had multiple wounds that he won't allow to heal. And so he'll come in and he'll have these surgeries that he's picked open, trying to get into the hospital. And it's like, you know, no, we can't. And we can't admit him because he is so dangerous. It's putting staff and other patients at risk. He's gone to other hospitals. He's been picked up by police. He's been there. He's been there, and he's been there. There's been forensic evaluations done on him, and he was not found mentally insane. He was not. He knows exactly what he's doing. He knows exactly what he's doing. He's very manipulative, which is how he's able to discharge, because he's not mentally ill. He's manipulative, and that's what makes him so scary.
So where do they take like the criminally insane people?
Usually the forensic unit at the state hospital.
Do you find many patients, family members that are enablers of their family member?
I'm sorry, I couldn't.
Do you find many patients through therapies and stuff like that they find out that their families are enabling them this condition or things like that?
Oh yeah, there's a lot of families that enable, and that half the time they don't even realize it.
That's what I was wondering, yeah.
Yeah, they don't even realize it, and so that's when it's beneficial to have that family session and just tell the family, you need to go to Al-Anon, or you need to go see a therapist yourself. You know, it would really help you if you were able to get some education, go to a support group on this topic, you know, and that way they can, they can get some support.
I know you see that in other things, but and I figured you probably had a lot of it here as well, so.
We do, yeah. There's a lot of enabling, especially with our recover patients, our substance abuse patients, you know.
What age range do y'all?
No, it didn't cover that. That's a good question. So on the 8th floor, it's 18 to 65. Of course, we do take outliers. If there's, you know, 70-year-old who wants to detox, that health is well, and you know they can do their own ADLs and get up and down. Because you know our beds. I guess I should tell you how our rooms are set up. That might help you understand our unit. So we don't have typical hospital beds. They're wooden boxes that are bolted to the floor with a mattress on top. And it's like that for safety. Because think about that. Think about what a person can do if they are suicidal and you have a bed that has all these like pinch points and they have cords and a sheet. Think about what they can do. Yes, that we have the tearaway curtains. We don't allow belongings. You know, we have to look through everything, and they're only allowed to have certain things in their rooms. Yeah, we only have one hospital bed, and that's in PICU, and it's in line of sight with the nurse's station, so that we can keep our eyes on all times.
So you have a little leeway above that, but you can't go under it.
We don't go under 18. If there's someone who needs help under 18, or if they're still in school, because state law mandates that you have to, if the person's in school, you have to provide school. So we are not allowed to take someone, even if they're 18 and in high school, we can't take them. So they need to be 18 out of school. So yeah, 18 to 65. But if they're under, they would need to go to like Pinnacle Point or Rivendell. Bridgeway. Yes, ma'am.
So young man, there was, self-mutilating,
Uh-huh.
would you call it fictitious disorder?
No, no fictitious, and I don't have my DSM in front of me, but I'm not sure exactly what the B code would be for that.
Okay. And I'm sorry, I missed your introduction. I came in a little late. I didn't know you were therapist. You were a nurse.
Yeah, oh, it's okay.
Thank you.
Yeah. Yes.
So like back to the bed situation, do they have like a pillow and a sheet in there as well? Do you just like monitor more at nighttime?
We do 15-minute checks 24 hours a day. We're constantly walking the halls doing 15-minute checks, and we have cameras that watch down the hall and cameras in the PSCU rooms. So we keep a close eye on our patients. But yeah, they have a sheet and they have a blanket and a pillow. You might be tripping. No, we have PCTs up there. They do the 15-minute checks, they do vitals, they will help get people checked in, so that means they'll log belongings, put the belongings back in our storage area. We have so many different things that come up, you know. Sometimes they'll ride with the patient to court, you know, that has to, because we always have to, if a patient has to go off campus, we have to send a staff member with them for safety. So they'll go with security and then we'll send a staff member.
I take the kids to the students to the 7th floor, and when we're talking about patients or something in the little lounge or whatever they're looking at, your windows are that must be the psychiatric floor and stuff like that. They can see the bars on y'all's windows.
Yes, that's our unit.
And that's very recognizable to them.
Yeah.
What?
They come up to the day area. We have a little area where they'll sit and they have a vital machine there.
Okay, so are there like alarms in place in the room for like codes or suicide attempts that, you know, you've got to say that help them through the buttons and stuff?
Yes, yeah, we have the code system. And we have also alarms in place if there's ever a big issue, you know, where we need all security up there or something like that. We have that sort of alarm in place too.
Will the CSM-5 be available to us to do, assignments as students on the floor?
No, we don't have it up there, Bernadette, but I can show you where we will get it.
Oh, okay.
Are there any other questions?
Thank you.
It's, you know, I've worked for Baptist for 13 years and, you know, I have no intention of leaving behavioral services. You know, I love the people I work with and the patients we serve. You know, we have a staff that really cares for our patients, that they want to help them. They're such a vulnerable population that they really need people with their best interests at heart. And I honestly feel that our staff has their best interests at heart. They work really hard to take care of our patients, and you know, they're always, our nursing staff, and therapy staff, OT, they're always trying to think of ways to better care for our patients, whether it be, you know, we make care packages for our homeless patients. We are always trying to think of ways to do more activities and groups with them. You know, you know, I feel like sometimes we see the same patients come in because they get so much support from the staff. So that's a good thing and a bad thing, you know, but as far as them coming in. But I don't know, we have a good staff.
When they do their therapy sessions, if, like the guy that came in, and if they're kind of sketchy like that, and you want somebody in there with you, who you call them?
We didn't admit him to, I went and saw him in the ER, and so we did not admit him to our unit. But if he wasn't there, I would probably, which I always tell the therapists, don't do therapy sessions in the rooms. You bring them out to the day room, and that goes for you guys too. If you're meeting with them one-on-one, don't meet with them in the room. You bring them out to the day room, just because, you know, you're working with people who can either be dangerous because they're psychotic, or you know, they can have personality disorders, and so sometimes things can be misconstrued or misread, and so for your own safety, your own protection, it's always best to do your interviews, do your sessions in the day room.
So do you all have cameras in place in certain areas?
We do. We have cameras in the rooms in PICU. We have cameras that look down every hallway up there. We have cameras in the day room, across the nurses station, that looks at the entrances to the unit. So there's not really a place on that unit that you can go, except for the bathroom, that's not monitored. Even the doctors' offices where they interview patients, they're monitors, because if a patient becomes agitated, we need to be able to watch and, you know, make sure everybody's safe.